morning, ladies and gentlemen. Thank you once again for joining us in our Humanizing Innovation webinar series. This program is organized by ICEC, the Industrial Collaborations and Engagement Center, and co-organized by the Advanced Health Research Program. Together with us, we have two eminent speakers for today's topic on advancing technologies in healthcare. Our first speaker for today is Dr. Kale Arusu. Dr. Kale Arusu Periasamy is the Director for Institute for Clinical Research, ICR, at the National Institute for Health, NIH, at the Ministry of Health, Malaysia. He is also an adjunct professor at the Taylor School of Medicine, Malaysia. He received his master's and fellowship training at the Royal London Hospital and the Royal College of Surgeons, England, and Royal College of Physicians and Surgeons, Glasgow. Dr. Kale Arusu has published in index journals, scientific proceedings, books, and presented his work at various international conferences. He is also on the editorial board of several indexed journals and is a recipient of the prestigious Jens Andersen Award for Traumatology. In 2017, he was awarded the Fellowship of Royal College of Surgeons, Edinburgh, without examination. His research goals are to facilitate clinical research for better clinical outcomes. We welcome you, Dr. Kale, and thank you for joining us this morning. I'll go on to introduce our second speaker for today. He is none other than our very own Professor Dr. Muhammad Faisal Ahmad Fauzi from the Faculty of Engineering, Multimedia University. Dr. Faisal received his Bachelor's of Engineering in Electrical and Electronics Engineering from Imperial College London, UK in 1999 and a PhD degree in Electronics and Computer Science from University of Southampton, UK in 2004. He is currently a professor at the Faculty of Engineering, Multimedia University, and he is the head for the MMU, UKM, IMU, Artificial Intelligence for Digital Pathology, also known as the AI4DP Research Excellence Consortium. His main research interests are in the area of signal and image processing, pattern recognition, computer vision, and medical imaging. From May of 2013 until June of 2014, he was attached to the Clinical Image Analysis Lab at the Ohio State University, USA, where he worked on digital histopathology, especially on cancer and disease analysis. He has published over 100 journal articles, conference articles to date. Dr. Faisal is a senior member of the IEEE, which he joined in the year 2000. He is currently serving as chair for IEEE Region 10 Newsletter Committee. He was also the past chair of the IEEE Malaysian section, as well as the advisor for the IEEE Signal Processing Malaysian chapter. And we would like to welcome Dr. Faisal for today's session. Welcome, Doctor, and thank you for joining us this morning. I am your moderator. My name is Saravanan. I am a full-time professor attached to Multimedia University. I teach in various areas such as semantic web algorithms, Web 4.0, data analytics, blockchain, and fintech. I have served the university, Multimedia University in various capacities in the last 21 years, and I've also worked for IBM World Trade Corporation for 7 years before joining the university. Currently, I'm working on a prognosis model for osteosarcoma, also known as bone cancer, with my collaborators at the University Malaya Specialist Center and the Faculty of Medicine. So without further ado, let's get started with today's session. So I'll invite Dr. Kale to share some of his work with relation to advanced technologies in healthcare. Over to you, Dr. Kale.
Good morning, and thank you very much for the very kind introduction, Professor Saravanan Muthaya. And also on this morning's webinar, I'd like to also acknowledge Professor Mohammad Faisal. It's good to be on this platform this morning, talking about humanizing innovations. I come from the Institute for Clinical Research. This is one of the research institutes within the National Institute of Health. We take on the clinical trials mostly, but also looking at human studies and looking at first in humans and various drug trials, and also the use of technology for purpose of clinical outcomes, whether it's preventive, diagnostic, or whether it is analytics. So let me share some of those thought processes, Prof. as you mentioned, about advancing technologies. I shall just spend some time just walking through some of those work the Institute has been involved in bringing forward some of those technology, particularly in COVID-19, which we all are very much impacted. And so, next slide, please. So what is healthcare technology? To just very quickly understand, this essentially covers many things we do in hospitals, clinics, and our patient-centered services. And these can be tools, they can be systems, and the systems can be technology-driven, and the systems are essentially all part of the healthcare delivery process. Now, if you're an administrator, you rely on technology. If you're a clinician, that will require you to diagnose and intervene preventively and also undertake analysis. All of those things involve technology. So essentially, healthcare tech is a key word that all of us must understand in how this has become part of us in the way that healthcare is delivered. Of course, now we are taking on the cue from both of you, the usefulness of big data, machine learning, artificial intelligence, and how this has converged towards providing precision medicine and also remote monitoring management system. So this is where the new knowledge and science is driving medicine, particularly the usefulness of data. And so you now see digital healthcare and almost the term digital health is synonymous with healthcare now. And through that, we see the usefulness of even robots and AI-driven technology that allow us to undertake from minor procedures to major work, even including cardiac surgery. So that is the advancement of technology in the provision of healthcare services. Next slide, please. So this is just to give you an insight on where we are for COVID-19 in our country, just to take a view of the sort of things that we need to understand, why there is now an upsurge, not only in the way we undertake technology in medicine, but also how we use it for COVID-19. So on an average basis now, we have about 19,000 over cases. We have crossed over 20 million first dose in vaccines and about 16 million doses in second doses. And therefore, we are complied with trying to achieve at least now 50% of the population being vaccinated. This is huge data that essentially is crunched to give us a simple static view of a day-to-day outcome of COVID. This is technology-driven too, whereby all of those information is collected on a day-to-day basis from all the sites in the country. And through that, we generate outputs. And this is very important for policymakers and also for the way that the public visualizes these COVID situations. So you can see from 1st February 2020 till now, we are into the third phase. We're just beginning to see the downturn of new daily cases. We're still averaging about 18 to 19,000. But this is a sort of analytics that allow us to plan ahead for COVID-19. Next slide, please. Another view of who we are in Malaysia, we are generally a young population, of course, with aging population increasing over the years. Our median age is about 30 years, and that's important because technology is very much a young population-driven tool. And if you look at the population that have aged, and the usefulness of technology for them being very high for COVID-19. We know the worst outcomes are for the elderly population, but the internet and the technology penetrance for this group is in fact defined by the dynamics of the age. And more than 60 years of our population in our population cohort, that's about 10% of them. More than 10% are in this cohort. And they must now relearn and learn to use technology, and especially in COVID, because they are the most impacted by the outcomes. Next slide, please. So just looking where we are in Malaysia in terms of resilience in this pandemic era, a landscape will give us an idea that majority of our population are urbanized. They live among the coastal cities, as you can see in the colory path of Malaysia. 90% or over are internet users using smart devices, essentially connected with mobile tools that are connected to either 3G or 4G network. And we see that in this group, more than 80% are connected to 4G network, essentially through the urban area. And this is how we can utilize technology to advance healthcare, because we understand the population better. Next slide, please. So to improve these, there are other necessities, the infrastructure. I think the country now understands the way forward. There are now national framework to scale up data centers and cloud services. We have learned from the experiences from many Western society or the advanced economies how we need cloud services in healthcare for those who are in fact using many of this technology. They depend on cloud services for analytics, for data repository, for retrieval of archive information to undertake trials and so on and so forth. So we need to now embark on a journey for our country to enhance the capacity for example, data centers that are based in Malaysia, and they can be linked with service providers like Amazon Web Services, Microsoft Services, Google Services, and so on and so forth, and tied to our own industry in our country. There's also now a need to strengthen connectivity. Many of the technologies have become so advanced that they need the super speed of 5G network so that analytics and decision can be made in an instant rather than number crunching through the old way of 3G. So this is where the fourth industrial revolution from training people into data analytics science to the user end for the products to rely on technology. So we will see these coming into our country as we develop as a nation as well. Next slide, please. So just on the pandemic, let me just give some examples where the Institute of Clinical Research has been involved for the purpose of, can I have the next slide, please? Yeah, next slide. Yeah, so this is important just to give us an illustration of how we have been involved in the analytics. So one of those things is that we have learned is that we can rely on telehealth, telemedicine, and this is through connectivity. And we need tools, we need gadgets, we need solutions, we need algorithms, and we need secure connectivity that complies with medical regulation, data privacy, medical privacy, and so on and so forth. And this is where technology has seen its, in a way, the usability in the pandemic. For example, this is a picture of a tool that we worked with in research and now in development, as well as in trial mode and also in the rollout mode, an artificial intelligence-driven stethoscope. And it can read sound of your heart and your chest sound, and it can give you what is normal, what is abnormal, and can point towards what is the issue about your heart sound and provide clinicians with the diagnostics. And this is portable and it is user-friendly, and it just be placed in a certain part of your chest. And by connecting you through what we all know, Bluetooth technology, Wi-Fi technology, it gives the clinician the map of the heart sound wherever you are, geolocated, and it can give you diagnostics. And this is not only the same sort of tool, there are many, many tools that rely on such artificial intelligence technologies. And I will give you some examples of where the Institute of Clinical Research has participated in advancing such technologies and bringing a human touch to this technology, how it become a day-to-day tool and not an investigative tool in the hands of clinicians and experts only. Next slide, please. So one thing that we learned from the early part of the pandemic is that we need tools, technological tools to help us model the disease and how it's spreading. You saw earlier how we know on a day-to-day basis, we can pick up the 18 to 19,000 cases. It's not easy without technology to get that kind of data convergence. And then from that to use modeling techniques to predict what is the infectivity, the local spread, what is the R0, RT value, and so on and so forth. The data that is also compiled is useful for capacity planning. How many beds need to be open? What is the ICU capacity? The need for field hospitals and repurposing of hospital back to full capacity as a COVID hospital, so on and so forth. This comes from data crunching and analyzing the trend of admission, discharges, and the length of stay, and so on and so forth. We can now, of course, visualize this information, and this is where there's a center, of course, within the Ministry of Health that look at the situation and actively manage the COVID pandemic and rolls out many of those much needed standard operating procedures. And also for clinicians to make clinical decisions, such data is analyzed. There's such vast data that is secure now that we use for analytics. And where does this come from? And this is where we clinicians and researchers play an active role. And I'll just walk through the first study that we did last year at the early part of the pandemic. Next slide, please. So this is now a published work. You can reference this work. It's one of the publications that came out in the Lancet Regional Healthcare. I was part of the study team when in the first wave and the second wave of COVID-19, we collected almost 6,000 cases from day of admission to discharge, and even for those who died. And we looked at the entire clinical journey of every single one of those admitted 6,000 population, cleaned up the data. It came from 18 hospitals. And how was this connected? We had a research electronic data capture system, technology and work. And so with a unique identifier for those researchers and the data being anonymized for all the 6,000 participants, this data can be centrally analyzed at the Institute for Clinical Research. We can create the output. And from this output, what did we find? We find that majority of COVID cases were young people in the first wave and the second wave, majority being male, mild cases, 3% or so deteriorated to the need to use ICU. And there was a fatality of about 1.2%. So this is where we then can plan for the situation of the COVID, because it gives us a basis to understand what are those complications that would determine poorer outcome, liver diseases, for example, kidney diseases, for example, and those with pre-existing respiratory illnesses. So technology allowed us to collect data from all these hospitals where we don't need to travel to collect data. It's all done through an electronic capture system that is cloud-based, a RedCap system. So this is one example how we initiated the human approach to use of such technology in research in the COVID-19 pandemic. Next slide, please. Then there were challenges trying to diagnose COVID. And, there was a struggle initially because there was not much known about this disease as a new coronavirus. The name changed from a Wuhan virus to a coronavirus in a matter of months. And there were different symptoms, but again, from different countries, you could now collate those information and create a diagnostic tool. And so now patients can be triaged before they even arrive at the hospital by entering into a mobile device, putting in their symptoms, their travel history, their contact history to give a probability that they are potentially a COVID case or not COVID case. So in a way, you are already giving a diagnostic indicator to prioritize them for early investigation, so on and so forth. Next came tools that allowed us to predict the severity of the disease. So the use of chest x-rays and CT scans, and then using AI technology by learning from these databases and teaching these machines, you can then allow clinicians to help not only in diagnosis early without the the tool that they had to diagnose, the PCR test. You could already give an indication of diagnosis just using chest x-rays and CT scans. And then there were many different technologies that came in for the PCR test. Some were the standard tests that took, sometimes even 2 days. Then there were rapid tests, then even antibody-based tests, antigen-based tests. All of these are new technologies developed priorly for the pandemic. And then the immunoassays, so targeted for those who had disease and those who carry the infection. So we did some work in this area. In all of these areas, the Institute has been involved. I'll just share with you one such example. Next slide, please. So this, we use saliva, and then using these antigen-specific testing, you could then allow rapid turnover of a diagnostic test for the laboratory diagnosis of SARS-CoV. Within 20 minutes to 30 minutes, you could diagnose purely by looking at the color change for whether there's COVID or no COVID based on the SARS-CoV-2 virus. This was the worked with the Sungai Buloh team and University Malaya Professor Lau in making this. This was a very important publication that came out from the use of saliva as well as for many other situations for the diagnosis of COVID in this era. Next slide, please. And this study too used the extracted sample from the PCR to validate the study. The next work that we worked was on the use of breath volatiles. And this is very important because, each time you breathe in and out, you create a certain signature. We call it organic compound signature. And these are biomarkers. And these biomarkers vary according to the disease. Whether you have tuberculosis, whether you have cancer, colorectal cancer, or lung cancer. This has been proven from previous work. So similar technology has been used in COVID-19, and we did similar work to make that happen. We worked with a research firm from Singapore and again with a European entity that looked at these volatile organic compounds and whether we can use this for screening of COVID-19. Next slide, please. And interestingly, if you compare here, there are two various types of viruses. COVID-19 is coronavirus, and influenza virus is not the coronavirus, but they create different breath volatiles, and these can be mapped to a color pattern. And you can see the chart on the right-hand side. This is from published work versus healthy controls and healthcare workers and COVID-19. You can already picture the changes, and through these, you can give a positive and negative predictive value of COVID-19. So detection using breath becomes possible. And these are already being practiced in some entry points. If you go into Changi Airport now, you can actually use a breath analyzer to give you an indication of COVID-19 through your breath. They can be tested. Likewise, in Malaysia, there are already service providers who are rolling this out, and we have participated in this study. Next slide, please. Next comes in MySejahtera. I think our Malaysian population has learned how to use this. Now there are more than 20 million unique users, and through these, you can update your COVID-19 status, your contact with a virtual advisory. This is to offer you suggestion how to do your own symptom analysis, how you could quarantine at home. And this is just a virtual doctor. Technically, this is the data that's telling you from all the data that we provide. The information is collated and allows you to recognize certain patterns and through that offer information. The system also allows you to book appointments. That is important because you don't want to overexpose people by crowding into spaces and therefore increasing the risk of spread of the COVID-19. You can also identify COVID hotspot around your living area, your work environment. In the last 14 days, how many cases have been notified? And also now it's a tool to follow your vaccination, whether you're vaccinated or not, what are the vaccine platforms offered to you. So this is unique to you, it's a unique identifier, and it's tied to your handphone and yourself. So it's now almost a digital ID that is mobile. Next slide, please. So this is an example of how a mobile clinic appointment is made. And this is important because you want to less expose yourself and also healthcare providers by not crowding in these places. So this online platform, again, technology driven, both for the administrator and for the clinician, to stagger your appointment, to optimize your clinical time, and also to plan the surgery or the appointment. So all of these are technology driven, comes from the big data, the analytics, the artificial intelligence that looks at it. Next slide, please. So I would like to just finish by going through one very important innovation that we did, and that sort of ties in with the topic of today, which is to humanize innovation. So the Institute for Clinical Research, through its Digital Health and Research Innovative Unit or Center, they developed this in partnership with many other partners, called COVID-19. So this is a digital quarantine system and home monitoring, now used for COVID, but eventually can be rolled out for other NCDs and even post-surgical monitoring at home for those are deemed able to be monitored at home. Next slide, please. So what is COVID-19? It's a quarantine system and home monitoring solution. It's real-time. It offers monitoring of progression of disease. It also has a dashboard that allows you to have analytics. And through that, we can figure out what is a trend of those who are being quarantined. And also it alerts the healthcare provider as well as the patient should they leave the premise, and also the healthcare provider of a risk of deterioration that it require early hospitalization. That is very important, which is much more active than a static model of just data entry. Next slide, please. So this is the architecture. What it does is, in a way, there are three major components. This is the mobile application. Currently, it's developed for Android systems, and through the application programming interface, the API, it is married with a biosensor. So these biosensors are in fact Wi-Fi enabled or Bluetooth enabled, and so they can capture your temperature, your oxygen saturation, your heart rate. These are the major clinical parameters in COVID-19, and through again the application programming interface, it's mapped to the COVID-19 secure web portal, which is cloud-based at the NIH. So the transfer of information is completely secure and protects the privacy in compliance with the law of the country. Next slide, please. So what does it do? At the point of entry, the clinician can register if the participant is a home quarantine person, and then it allows the person to download the COVID-19 into their handphone, and then they need to validate their presence at home with the application in the handphone with the biosensor, and this is validated. So this is checked through the back end of the system, and then on a day-to-day basis, they can transmit information and they can improve their connectivity by doing more regular transmission of information, and this is reviewed by the healthcare person behind the dashboard remotely. Next slide, please. So what would the participant do on a day-to-day basis? They validate their temperature, the clinical signs, and also answer some simple questions to indicate if at all there is any deterioration or any changes to their system. But of course, the validated biosensor picks up the temperature, heart rate, and oxygen saturation, and using an algorithm to risk stratify them, you can predict whether they are likely to deteriorate or not and monitor them. Next slide, please. So this is how the dashboard looks like, and that's a picture of one of our research heads, and he's just put himself where he is, so it gives you a geolocation, and you can have a symptom tracker and also a latest vital sign tracker. And you can see how if you're not validated, the system auto-informs, and this is where you are personalized in the way you're monitored. You can geolocate this person or even geofence this person to 50 meters or 100 meters around the house. So if you breach your quarantine, the system can notify you, kindly please return to your home because you're home quarantine. This is how effectively the system can work. And this is through the connectivity I mentioned earlier, the 4G network and the 5G network with super speed connectivity. This will be very much in everybody's hand and very efficiently rolled out. Next slide, please. So what would be the outcome? The outcome is it allows safe monitoring. It offers immediate response to the home quarantine participant as well to the healthcare provider. It reduces the burden of healthcare. You don't have to, go to your clinic without the need to do so. And also virtually now, you can have this assessment and it's integrated with the same device I mentioned earlier, your MySejahtera, the unique identity that you carry with you now. Next slide, please. And so these are in compliance with the essentials of a secure data system. Secure is robust, it offers notification, and also the IP is the Ministry of Health. So this is how we have rolled out this particular solution. So one more slide, please. So here, where it is going to go. So in future, you can use the same technology to enable other advances in diagnostics, in quarantine monitoring, and also post-treatment monitoring, even long COVID, for example. So now we are developing the next solution using cough sound for a diagnostic and database library. And from this work, in collaboration with our local partners in University of Swinburne, many others too, develop a cough sound or sound-based diagnostic tool at home. So you can go at home, try this technology to see whether it indicates you're likely to be COVID or not, purely because your sound change indicates that that is these COVID potential. So not only your breath, your sound too can become useful the way you use this. And all these variables the entrepreneurs are working to develop, they can use, they can be used to expand into other monitoring systems like diabetic monitoring. You can look for post-surgical monitoring and those that require oxygen saturation monitoring. So this is how the technology will become user-friendly and also very precise to the person. So it becomes, you know, very much valued for the user interface. Next slide, please. So in this, we understand the need for strategic partners. And so I welcome MMU's invitation to look into this partnership in research and bring forward some of the solutions I'm sure MMU has developed together with many other clinicians. I take the point that Prof. Saravanan is already working on osteosarcomas with University of Malaya. We can likewise work with clinicians from Ministry of Health. I understand that previously we have worked on wound healing technology with images with MMU and the wound care team. And likewise, you know, Prof. Faisal has many other solutions we can work with. So this just to illustrate, just for one technology that is being utilized now, the Kodik, so many partners have come in together to drive it. And I think this is what the future is for Malaysia, in making all of these partners come together to drive innovations in healthcare and then to bring it to human use. And so in summary, I like to say that the future of healthcare now is digital. And I think that is where we should focus a lot, but you still need a medical base and healthcare base. And there's need for collaboration, of course, between the source of this information and science and the advancement in technology, basically the academia, MMU, being there, the industry players who are able to drive those solutions into real devices, and then to marry that with what clinicians want for disease outcomes. And so I feel that, you know, for this humanizing of innovation, really we should be driving much in healthcare too, because this is what we do on a day-to-day basis. Health is living, so humanizing healthcare is in fact use of technology. And with that, I'd like to thank all of you for your kind attention, and then back to Prof. Faisal and Prof. Saravanan to continue with this webinar. Thank you very much.
Thank you so much, Dr. Kalai, for that very fruitful, insightful knowledge sharing. Let me just quickly invite Dr. Faisal, and for the Q&A for Dr. Kalai, let's hold off the Q&A until Dr. Faisal has done his presentation. Thank you so much, ladies and gentlemen. Over to you, Dr. Faisal.
Okay, thank you, Prof. Saravanan. And also thank you to Dr. Kalai. Okay, it's a very interesting talk. Okay, this is also a reason why we, you know, when we are asked, the research program were asked to co-organize this webinar. Okay, the first person I have in mind is to have somebody from NIH itself. Okay, and who's better than to have Dr. Kalai, who is the director for the ICR, okay, to share with us, okay, the technologies currently in use, okay, and also what are the opportunities, okay, that we can have in having this improving or advancing these technologies in healthcare together. Okay, thank you, Dr. Kalai. For my talk, basically, I'm just going to Dr. Kalai already share with us, okay, the current technologies currently in the healthcare sector. For my talk, I'm just going to share a bit about the research that we are currently having in Multimedia University. Okay, and we have a research program called Advanced Healthcare. Okay, and before that, my name is Muhammad Faisal. Okay, I'm a professor at the Faculty of Engineering, and this year we are also very honored to have to be selected, okay, to lead this what we call the Research Excellence Consortium. Okay, it's an initiative by the Ministry of Higher Education. We work together with UKM and IMU for this Artificial Intelligence for Digital Pathology Research Excellence Consortium. Okay, we'll go a bit about it later. Next slide, please. So we have this Advanced Healthcare Research Program. Is basically the program focuses on utilizing advanced technologies, okay, or developing advanced technologies in different aspects of healthcare, okay, in order to improve healthcare system. So we have many researchers, many academicians that is working on this in collaboration with different hospitals, okay, different medical centers, different pathology labs, for example. The idea is, to work on advanced technologies, okay, and in healthcare, this includes diagnosis, prognosis, treatment, rehabilitation, even lifestyle. Okay? And when we talk about advanced technologies, okay, I think Dr. Kalai also mentioned just now, okay, currently artificial intelligence, machine learning, these are the the hot topic. Also big data, okay, the hot topic in even healthcare technology right now. So we are also focusing on this. Okay, we also have signal and image processing, data analytics, okay, virtual reality, augmented reality, okay, 3D modeling, 5G, and so on. So the good thing about this advanced healthcare research program is that our researchers come from many different backgrounds. Okay, later I'll share with you our members. We have researchers from different faculties, from engineering, from IT, from management, okay, and many other faculties. Okay, so you can see we work together in this case. Okay, and the outcome, okay, we want to improve the quality, increase the productivity, okay, also to have better patient care, digital hospital, and so on. Okay, and also we are working on technology acceptance. Okay. Acceptance by medical personnel, okay, acceptance by patients, by hospitals, okay, as well as the general population. Next slide, please. Okay. Just quickly to share on the objective here, okay, we want to bring together researchers from different backgrounds, okay, to work on these advanced technologies. We also want to increase collaboration, so we welcome Dr. Kalai's invitation just now, okay, to work together, okay, with NIH. Okay, we want to work with national, international industry, okay, hospitals, labs, okay, and also we want to go for joint grant submissions. Okay, we want to elevate, okay, our program, okay, into a national high COE status, okay, and also maybe become a referral point for anything related to health technologies in healthcare. Next slide, please. So the motivation for our work at MMU, okay, because most of the practices, okay, currently in the healthcare sector is still based on manual or analog routines. So that's why this is where the advanced technologies, whether it's AI, big data, or machine learning, can be incorporated, okay, to assist doctors. Okay, I think this is a very important keywords. Okay, to assist doctors. Okay, we don't want to replace, okay, the doctors or to replace the pathologists, okay, the radiologists, but we want to assist them. We want to come up with the technology to assist them, okay, in their clinical routine, okay, in decision making, okay, diagnosis, and so on. Okay, and also, of course, the technology is not only for the hospital, but also, okay, can be used directly by patient. For example, just now Dr. Kalai shared MyCodic, okay, and a few other inventions just now. Okay, can be used by the patient and also general population in their disease treatment. Okay, and the acceptance, okay, of these new technologies, okay, among medical personnel, okay, among hospital, okay, and also among patient, okay, currently is also unclear. Next slide, please. Okay. Okay. When we talk about artificial intelligence, okay, for example, here we give an example of breast cancer. Okay, breast cancer is missed like 10 to 13% by even expert mammographers. Okay, not to say that they miss this by by chance, but basically there are many factors. For example, can be fatigue, okay, or distraction, okay, emotional stress. Okay? Because for example, for some cases they need to spend hours, okay, studying a sample under the microscope. So these lapses can set in. Okay, we also have variation in the readers, okay, and also satisfaction of search. And research has shown that the sensitivity, okay, in breast cancer detection, okay, can be improved by 15% through double reading. So if we have a technology, okay, that can assist the doctors here, of course it can also further improve, okay, the cases of this missing detection and so on. Next slide, please. For example, in this case, we share digital pathology. Okay, we have a pathology workflow. Okay, so pathology is basically also one of the work that we are focusing on at MMU. You can focus the workflow in blue. Okay, the one in red is actually currently in analog. Okay, workflow. Okay, currently work has been done, okay, to replace this analog workflow with the digital workflow, which is basically in blue there. Okay, this will involve scanning, storage, digital diagnosis, okay, digital quality assurance, and next slide, please. Okay. And the timing also is basically just nice. Okay, especially for this in this pathology. Okay, only in 2017, okay, quite recent. Okay, the US FDA have permitted, okay, the marketing of the pathology solutions, okay, in order to carry out the diagnosis. Okay, previously we have this system, okay, whole slide scanning, but it can only be used, okay, we can basically the pathologist cannot use it to do diagnosis, okay, to make a decision based on that. Okay, but now with this new development, a lot of work has been carried out, okay, in this area to automate, okay, this process in digital pathology. Next slide. Okay, and of course, with this new technologies, okay, the advantages, okay, is in terms of quality and productivity. In terms of quality, it can improve the analysis, okay, it can reduce errors, okay, like we mentioned just now. The errors can be because of fatigue, okay, and also the other lapses. Okay, they can also provide better views, okay, and in terms of productivity, they can improve the workflow, okay, and reduce the turnaround times. Okay, for example, some cases for cancer, pathologists have to spend like 2 or 3 hours, okay, in order to really diagnose, okay, a patient. And if you're able to do this, okay, make use of these technologies, artificial intelligence, big data, okay, we can reduce these turnaround times, okay, which is basically will be very useful, okay, very beneficial, okay, to the doctors and also to the patient. Okay, and of course, with this we also have more innovation. Next slide, please. But again, I want to stress again. Okay, all these technologies, okay, basically, we is intended to assist, okay, the physician, okay, to assist the doctors, to assist the pathologists, the medical personnel, okay, in order to make a decision, okay, whether it's a radiology, pathology. We are not intending to replace, okay, these physicians, but rather to assist them. Next, please. Okay. And for this research program, okay, we make use of all this AI, machine learning, signal image processing, okay, virtual reality, 5G, okay, 3D modeling, okay, and all this in order to provide, okay, to address, okay, various levels of in healthcare sector, okay, the analysis, diagnosis, okay, treatment or rehabilitation. This is especially for precision medicine or personalized medicine. We are also currently working on with doctors in PPUM, okay, on breast cancer, where we try to come up, okay, to suggest a treatment, automated assistance for different patients, okay, based on their antibodies and so on. Okay, and also in terms of lifestyle, we have a work on post-treatment, okay, lifestyle, okay, especially for stroke patient and so on. Next slide, please. Okay. And in terms of here we focuses a lot on the diseases, okay. Especially myself, okay, I focus on cancer, okay, and also in wound care, okay. Other researchers, okay, they focus on Alzheimer disease, okay, diabetic, okay, cardiology, stroke, okay, especially COVID-19 now, okay, and some work on retinal, okay, disease. Okay. So we're also working on these different types of modalities. We have radiology, pathology, okay, regular photography, ECG, EEG, and so on. Next slide, please. Okay. So our goal is to come up with new technologies to help advance, okay, the healthcare sector. Okay, these are the policies, okay, that we believe, okay, we can contribute. Okay, we have this national policy on Industry 4.0 under artificial intelligence. Okay, national priorities area, of course, under the healthcare and medicine sector. Okay, and of course the sustainable development goals. Okay, we because this is a combination of the healthcare sector and also the technology. Okay, we are targeting goal 3 and goal 9. Next slide, please. Okay. I already mentioned about the sustainable development goal. Next slide. Okay, and currently, Malaysia have this 10-10 MySTIE, okay, which stands for Malaysian Science, Technology, Innovation, and Economy. Okay, so of course, medical and healthcare is one of the focus economic sector. Okay, so we are hoping to contribute to this. Next slide, please. Okay. And so all in all, okay, we want whatever technologies that we help to develop, okay, to be beneficial to as much people as possible, okay, to the patient, to the doctors, okay, to the hospital itself, okay, and also to the general population. Next slide, please. Okay. Here we I'm just sharing a bit of some example of the work that we are doing currently, okay, among our members. Okay, we have work on cancer pathology, okay, in terms of detection and diagnosis, work on prognostic reporting system, okay, again for breast cancer, okay, and also work on different kind of predictive markers, okay, HER2/CISH predictive markers, which is relatively new, quite new, so not much work is being done. We work with PPUM, okay, they have some trouble on carrying the diagnosis for this kind of predictive markers, so we are working with them on that. Okay, as I mentioned, we have work on retinal image analysis, okay, and also to track human activity in healthcare. Work on wound care technology, okay, wound care system mentioned by Dr. Kalai just now. Okay, and some other work we are currently planning. Okay, we are sourcing for grants, okay, like the medical chatbot, emergency response systems, okay, health monitoring, guidance, and also tracking, as well as the in terms of the mindfulness towards the societal well-being. Okay, this is on the mental health aspect, okay, of the patient. Next slide. So, like we mentioned, I mentioned earlier, okay, the interesting thing about this research program is that the members come from many different backgrounds. We have members from Faculty of Engineering, okay, from Faculty for Computing, okay, Faculty of Information Science Technology, okay, Engineering Technology, Faculty of Management. So this is a very interesting research program that we have. Okay, we always look for more collaboration. Okay, we look for more research work. Okay, also looking for more students to work with us. So we welcome all, to collaborate with us. Next slide, please. Okay. And this is just some of our, national and international collaborators. Of course, we are expanding this network of collaborators, okay, in order to, elevate, okay, our research program. Okay, I think that this is the last slide. Next slide, please. Yeah, I think that's it from me. Okay, I'll pass back to Prof. Saravanan. Okay, thank you very much.
Thank you so much, Dr. Faisal, for your presentation and fruitful sharing of your work. Just for the information for the those who are watching live and those who had tuned in earlier, I'm just going to summarize a few key points from both our experts as to what's really happening in terms of technologies in advancing healthcare. Dr. Kalai spoke about health tech, and there were many items there. One that really excited, kind of got me up excited was the AI stethoscope. I think that's really an very exciting area where such a modern and advanced technology can really help doctors to do wonderful procedures with their patients. He also talked about analytics on pandemic, and he talked about how this data collection, especially now during this pandemic, is helping us to actually monitor, track, triage, and also be able to help people to even understand where certain hotspots are, what areas to avoid, what has happened in your neighborhood. There's a lot of things that data is doing now. So it's about a data-driven ecosystem here that he actually explained very nicely about how they use this data to even identify potential cases. Then, of course, the evolution in the test kits, PCR, antigen test, that's really amazing work going on there. One thing that really caught my attention was the organic compound signature, which was something new that I learned today. Thank you so much, Dr. Kalai. Now I can actually at least quote you and talk about these things. I never knew that we had a color-coded, compound signature analysis. I've heard of color-coded triaging systems. We've actually seen that. We've tried to develop it with Hospital Sungai Buloh. But this one is just taking it to another level. Organic compound signature, guys. And of course, the My Sejahtera app, Dr. Kalai talked about the appointment, vaccine providers, and so, in a nutshell, becoming a digital ID. And lastly, he spoke about Kodik My, which is basically the quarantine and home monitoring system. And it can be used for geolocating, geofencing, and things like that. And then also moving on to using sounds from the cough to even diagnose patients. So I think that's a lot happening, guys. So I'm sure you have a lot of questions. You may want to ask Dr. Kalai later on. I'll just move on very quickly to summarizing main points, takeaway points from Dr. Faisal's presentation. Dr. Faisal covered the Research Excellence Consortium, one of the major projects that he's leading right now. A lot of things in using data-driven decision making, prognosis, diagnosis, particularly tools to assist and enable doctors to actually carry out their work faster and faster diagnosis, as what he pointed out earlier. He talked about mammographs, and he talked about how mammographers miss out, certain by 10 to 30% of certain cases, and he says that is quite normal because of various factors. And with this technology, on the improvement detection for mammographers. The improvement detection increases by 15%. And in 2017, the FDA also approved these pathological solutions. And also he went on to talk about post-treatment lifestyle and various other areas such as cancer, prognosis, and also wound care. So that's in a short. I had time. I know there were, there's so many things to write down. These were some of the main points that I could summarize. There's a lot more going on, I'm sure. I think we can do a lot of interesting work together with NIH. My students and I, we've just started a small group with my PhD students. It's called the Smart Healthcare Group. And one of my students is working on the project that Dr. Faisal talked about on the EPCR for the EPCR systems for healthcare. And also there's another group of my students who are actually working on the health tracker, which is used for better contact tracing, which is actually happening right now at the university. So that's where we are at, ladies and gentlemen. If you have any questions, you know where to post your questions. Our experts are waiting. And if there are no questions, then I will just continue the discussion. While the questions are happening, let me just ask Dr. Kalai to maybe talk a little bit about what's the potential risk or threat as we are now going to phase 2, and we are going to open up. People are going to start dining in, going out. So I'd just like to know, for the benefit of the viewers, Dr. Kalai, what do you think is our risk moving forward?
Okay, thank you very much, Prof. Sarwan. I think you really summarized our two, given talks just now very succinctly, and thank you for putting the clarity to what I was trying to say as well. Yeah, coming to your question, yes, when you move from a phase where you have mobility restrictions to a phase where you allow a freedom of some mobility to do those sort of things that socially we are all trained to do. For example, just going out for a meal. And Malaysians, you don't have to say much. Eating is perhaps the most important pastime, contributing to much of our problems in health anyway. But nevertheless, so when you are able to now technically unshield yourself, this is what you're doing. You unshield yourself, you make yourself mobile, and you congregate in places, close environment, close spaces. You are also potentially coming in contact with those who may be asymptomatic and carrying the virus. And this is the problem about COVID-19, that in the early phase, you do not know you're actually carrying the virus. And this is something called viral shedding. You shed. Shed means you technically, spread it by conversations, by sharing of meals. So dining in, one of the conditions obviously is to have a vaccinated, completed status. This is because at least, if you're vaccinated, you reduce the risk of transmission and disease severity. That is an important element versus those who are not vaccinated. So by increasing mobility, you will anticipate an increase in at least a certain spike in new cases, because all along you've been shielding yourself, staying at home or a very close environment. So we need to plan for that. But also because there is a spike, then your healthcare capacity need to be prepared. So beds again need to be there. Your doctors and nurses all need to understand there will be this transition from being symptomatic to being admitted, and then the need for oxygen, ICU care, and so on and so forth. And also sometimes you hear it all the time, a cluster happens because you allow mobility, people attend functions. And Malaysians, we congregate, we meet together, we shake hands, we hug, short of kissing each other, but essentially we are very close proximity. And so you again place ourselves and those within the close environment at risk. So clusters are likely to happen. And again, thankfully, in the phase 2, this is mitigated by the strength of the population being vaccinated. So we are highly vaccinated, but still we need to be careful about this. So masking still becomes necessary. People will ask, vaccinated, no need all this. You still need to understand it is a requirement because you want to prevent the spread. Being vaccinated doesn't mean you don't spread. You can still spread. So it's important. And public need to understand that. So going from one phase being shielded to an open mobility, of course, there will be some changes to the pattern. So we've seen this from the other states as well. So we need to plan for this.
Yeah, thank you so much. I'm actually speaking on behalf of my kid because they're talking about schools reopening and so parents are actually a bit skeptical. Some of us are a little bit worried, and the schools have just asked us, the parents, to give our consent for our children to be vaccinated. So we've done all that, and looking at last year's SPM examination, which was postponed a number of times. So students who are gearing up for this year's exam, and how they're going to actually start this whole school going phase will be something that you can never prepare for it really well. We try our best, but children being children, they touch everything. So I just hope that there's a school cluster doesn't happen.
You're right, Prof. First and foremost, it's timely that children are being vaccinated because, of course, COVID was worse. The worst outcomes are for the elderly population, those with comorbidities. And then we've seen the variants of concern and how the pandemic has become for those who are not vaccinated and also among the young. And now we have vaccines that are safe and effective for the younger population up to at least from 12 years and above. But again, as you mentioned, school is an important environment. Children need to make friends, go out and enjoy that what you and I had, a school life. We make friends at school and that friendship lasts a lifetime. That's very important. Imagine a generation of children who have not had that opportunity. How sad it will be if we don't make friends for a lifetime. It's so important. The next thing is learning. There's always a need for some form of physical learning. I always remember my teacher being angry and happy. And so the emotional contact with a teacher, a friend, is so important. That molds you. A character building comes there. But this is in the background of a pandemic. So there are other mitigation strategies. You're right. Parents need to be aware. You need to be vaccinated. As parents, you should be. And children who are eligible, when they're asked to be vaccinated, we should prioritize them, especially those at the highest risk, and offer those adults around the school environment vaccines so that they protect the children who cannot be vaccinated because they're young. Some are below 12. They can't be vaccinated. We don't have vaccines yet for them. And so they need to be protected. So adults, we take responsibility to safeguard them by getting ourselves vaccinated, ourselves symptom-free, ourselves not to be in contact where there's a risk of being potentially getting infected. The bus driver, the transport, the canteen operator, all of us take responsibility for the young so that they can have a safe bubble, a bubble at home, a bubble at school. We can't avoid a cluster, but we at least will have some of the technologies that might help us detect some form of variation. So maybe temperature monitoring, rapid test kits that are cheap, and your saliva-based systems. You don't have to, swab the nose. You just spit into a little container and test it. Breath maybe, sound maybe. So all of those things are important so that you can do this at home and remove yourself from being at risk by going back to an environment where you're potentially likely to infect others so that you can go through a proper pathway. So this is why I think we need to understand this technology is to facilitate us to normalize a new norm, and Prof. Faisal, you mentioned that data will drive this, technology will drive this. It eventually is about that. You may come to my office in future, not only scan your temperature, but perhaps blow into something. Yes, you're clean to go. That's what maybe we need to, you see. So, and then learning can take place, and teaching can happen. And you can go out in the field. Maybe now you no longer sit in a canteen and take your food among friends, but go out and sit in the field in the padang under the tree. You know, the wind is much better, a ventilator, than sitting in a closed environment. And all those things comes from science and data. And so we need to relearn, relive all these things. And Prof. Faisal and Prof. Saravanan, you know, you're the academics and the brains and, you know, the technology-driven people. And we work with you. You know, I'm so glad we have people that we can develop such knowledge and science. Yeah.
Thank you so much, Dr. Kalai. You have a question from our very own Prof. Faisal. The question is, doctors are very busy. I mean, you know, especially right now with this COVID pandemic situation. And as researchers and as academicians, we oftentimes want to collaborate and work with these very busy people. And because they are, you know, so engaged in their jobs, they don't have much time. The question is, how do we really convince them to collaborate and work, considering that sometimes they're trying to put out a fire today, right? But our research might only result on outcomes in the future. So the result may not be very immediate. So you got two problems: they are busy, and the outcome may not be so immediate. How do we still get them to work with us?
Okay, tough question, Prof. Faisal, but let me put in context. Okay, all of us who are trained to be clinicians, I think our primary service is to maintain essential healthcare. I think fundamentally a doctor, you know, they are all trained to prevent death and save lives. And in a time of pandemic, that's where the priority will be. And I think it's rightly so, because we don't want the whole environment to be in a way, it creates a panic environment when you don't have, you know, delivery healthcare. And this is so important. So doctors need to do that to prevent, you know, severe outcomes and prevent death and save lives. But the second point in context is you need research to help that. You cannot rely entirely on, you know, tested technology that doesn't apply. Coronavirus 2, the SARS-CoV-2 is a novel virus, just been here since about end of 2019. So in this time, we have had, you know, in Malaysia alone, 1.8 million people affected, now 1.9 million. So you can imagine the need for technology to help all healthcare systems sort of manage this. So how do we get doctors to help researchers, academicians like you, to participate and collaborate? I think, Prof, you mentioned something. We should have done this 10 years ago, this talk. And we should have developed sufficient data scientists, analytics with clinical mindset, and be able to adapt to this kind of situation. We are hampered, not only us, many parts of the world, where we have had very little investment in data scientists, analytics, and the ability. So our future doctors must be trained to do this from medical school now, undergraduate level. Data science becomes a major medical science, just not about the technology, the end of it, the artificial intelligence stethoscope. It is not the endpoint that we use the technology, but to understand how the technology itself was being enabled. So we need that. So we need more training. We need more capacity building, and that needs to be recognized. And so there needs to be a research pathway for clinicians so that they can advance in this field and complement the healthcare delivery system. And this is where I think our current doctors are juggling between provision of care and at the same time trying to adapt into a research environment and then cope with the need to take on all those tasks, you know, data analytics, make models, create algorithms, and then develop risk stratification, then come back to academician. Did I get it right? Did I get it wrong? And so I think the pandemic has taught us that we need that collaboration. We need more people trained. I hope that there are more PhD in this field now, and we are more than happy that we work together. And so institutional level, I'm sure I will facilitate that. You know, PhDs are what we need. Postdoc is what we need in this field. And something that the nation, the industry, the systems will look out for. And this is how we can entice more people. So being a doctor may in the future be that they take on these kind of pathways. And there's a huge demand for them because these require that kind of mindset. I hope I answered your question, Prof.
Yes, yes, you have, Doctor. So I guess the summary is that the synergy will happen and it has to happen. And even though we don't have the silver bullet to answer the problems right now, it's about time that we start working towards it. Yeah. Thank you so much, Dr. Kale, for your answer. Prof. Faisal, just quick question on the ongoing work at the consortium. Can you share a little bit about what's happening at the consortium, what you guys are doing right now?
Okay. Thank you, Prof. Sarah. I think the consortium is actually I work in this. My background is actually on machine learning, image processing, but for the last few years, since my sabbatical, I think back in 2013-14, I focus more on medical imaging, medical image analysis, and specifically in pathology. Digital pathology is, usually when we talk about medical imaging, the first thing that comes to mind is, the X-ray, the CT scans, the MRI. So those basically falls under radiology. Pathology is, for example, if you have cancer, and if you want to know more about the cancer behavior and so on, then you need to, to get the cancer sample, the tissue sample, and then this need to get analyzed under the microscope and so on. And I think since early 2000, I think they have this technology. Again, we're talking about technology. They have this technology to be able to scan this this slide in a very high resolution. We are talking about, could be 100,000 pixels by 100,000 pixels. So you can view the tissue samples, the overall tissues. You can zoom in very detailed, so you can see individual cells, the nuclei, and so on. And then, if in case of cancer, basically the cells will appear abnormal. In terms of breast cancer, they can be mitosis, they can be pleomorphism, and so on. So with this new technology, people are doing more of research on this area. But again, as I mentioned, even though this whole slide scanning is available since early 2000, but the doctors, the pathologists, they cannot actually make the diagnosis based on the digital these digital slides yet. They still need to look under the microscope. Or maybe they have some algorithms to help them, and then basically they can only use it as some additional tools to help them. But in the end, they still need to base on their interpretation from a microscopic slide and so on. But in 2017, like I'm in one of my slides just now, the US FDA have given this approval, to the marketing of this kind of system that we can have now fully digital system. The doctors can also now do the diagnosis, fully on digital slide. So meaning that they don't have to refer to the microscope anymore. So with this new development, now with this AI, big data, machine learning, now we are, it's in full flow. We are, but of course the challenges are still there. The challenges, especially when we talk about cancer, cancer is very complex disease. So some of it we are still don't quite understand yet. And then as I mentioned, the pathology images is huge. One image for one single patient can take 1 gigabyte, 2 gigabyte. So these are the challenges. So currently a lot of work is being doing here. But in Malaysia, we don't have dedicated lab, or a big lab on this area yet. We have MMU, myself and Dr. Fazli is working on it. I think I know of in UKM, some researchers are working on it. And then in IMU, but basically that's about it. So when the MOHI introduced this Research Excellence Consortium initiative. Okay, we jump on it. Okay, we sit together between us, MMU, UKM, and IMU, come up with a proposal. So we're now having a consortium that we can hopefully grow. Okay, we have the funding. Hopefully we can grow, become a national high COE, for example. Okay, and then create awareness. More people. Okay, currently not many people is actually working on this. We want more people working on this. We want to contribute to the the doctors and the pathologists as well. Hopefully, what technology we use not only can benefit the patient, but we can be used to train new pathologists as well. Yeah. So that's basically what the initial 2-year phase of this consortium is about. Okay, we have 3 projects. Okay, the UKM team is working on blood cancer. MMU is working on breast cancer. Okay, the IMU team is working on pancreatic cancer. Okay, so but we hope to grow. Okay, and then become self-sustainable, and then become a national referral point probably, okay, for anything AI in digital pathology. So that's the name of the consortium, AI for digital pathology.
Very interesting, name, and some very good work that you're doing. Congratulations, Professor, in your work. We have some questions from our viewers on the FB page, and the first question, again, I think Dr. Kala, is your day. A lot of people are excited about your talk. So first question for you, sir, is how do you see handphone technology and AI in diagnostics like X-ray to assist in detection? So basically, they're talking about using smart devices or smartphones, enabled devices to assist in X-rays and X-ray type detections, particularly in the COVID-19 pandemic situation. That's the first question.
Yeah, thank you for the question. As I mentioned earlier, I think we have had a high uptake of internet access in our country, more than 88%. That's the first point. And most of our urban cities have very high connectivity. These are the basic ingredients for smartphone applications. And for the use of a smartphone or this handphone-based technology, the main issue still are and will continue to be is who owns the data. So data ownership is very important. So if I have a chest X-ray, is it my X-ray, or does it belong to the doctor, or does it belong to the healthcare system or the hospital that I paid to do my test? So we need to have a platform that integrates data ownership into the system so that it's portable, number one. And so one, it is portable, that means interchangeability of access platforms that allows one to have a mobile platform. So your technology is now mobile. So if I have a chest X-ray in my handphone, technically I can show it to another doctor, say, can you please diagnose? Or now I can share that X-ray information with, say, like Dr. Faisal's, Prof. Faisal's team, and if he has an AI solution, and I can share that X-ray, and that offers me an indication. Yes, this X-ray is showing that I'm potentially going to develop, lung cancer in 10 years based on this current, series of X-rays, based on my history, the pathology that has come from. This is what it will become eventually. So we can govern the structure, data ownership, to how I share and how we utilize that information. So there is a huge potential for this. That's the first point. The second point is you now have a mobile technology, so it's real time. And your connectivity based on that, you no longer need to send a hard copy printed and send down by courier to have it, assessed and diagnosed by someone else. So it's real time. You can connect to many of those things. And if a validated solution, then it is as accurate as what another person would be. So if you imagine our healthcare system is decentralized from a GP clinic to a primary care clinic to a specialist clinic. So you don't have to burden the specialists with just routine X-rays and routine diagnostics, because you now have mobility of your data to share real time with many other solutions. So AI will drive that. So the real benefit of AI is for the user end. It so becomes value-based. So that at the entry point itself, I use it to decongest my specialist. I don't have to go and see the specialist all the time, every time, just to get a little diagnosis. So this is where I think even the pathology consortium that Prof. Faisal mentioned will eventually lead to. Specialized work should rest in specialized hand for specialized time. Routine work should rest with the AI-driven technology as good as, even better than human prediction in most instances. So I see that as the future for handphone, technology, and data.
Thank you so much, Dr. Kalai. There's also another question on how we can actually work and collaborate with NIH, and there's a question on, is there any plans moving forward for collaborations between NIH and collaborators from the universities? Anything going on? I think you mentioned something about MOU that's already there.
Yes.
Maybe
So the good thing now is there's some clarity on some of those areas in terms of how we collaborate. We can draw, what we call understanding between our institution, and that is being facilitated. And we are already collaborating, not to say we don't have collaboration. We have many collaborators. Just that, there are different regulatory, layers. So this consortium example is a good example, how you bring people of different expertise into one platform. And we see the benefit of such relationships. So we can draw on such examples and lean on each other's expertise. The collaborative model is often driven by a research platform. That is the base. So I remember a couple of years now that, when the Prof. Faisal's team was working with the wound care team, this is how collaboration starts. There's a need for something from the clinician perspective. Can I just look at images, take pictures of a diabetic wound? Can I predict what direction it's going to go? And so that is ministry. Clinician wants to know at the point of entry, what am I doing right or wrong? Can I tell the patient, hey, look, if you do this rightly now, I can promise you in 6 months or 3 months, this is where you're heading. But that kind of work needs collaborators, someone with the science to help that translate and bring that into reality. Prof. Faisal team did that, and that work is ongoing and has shown positive outcome. And that is how you build on. Once you have a platform that you can collaborate with a clinical team, and this is why, like even pathology, your case of cancers, you develop that platform. So research would be the ideal. NIH is that. It's a research institution. And there are several of those, from behavioral science to public health to medical, biomedical, into behavioral and health systems, and so on and so forth. So we have that opportunity. And there's also advanced capacity at the NIH level. If you walk into IMR, some of the facilities are top range in the country. So we need to lean on that facilities in this sort of engagement. And so research-based platforms are always ideal, and then only the stakeholders will see the benefit of it. Yeah.
Very, very exciting times ahead, Doctor. Thank you so much for your inputs. And once again, we do not have any more questions. So I'll take this opportunity to thank both you gentlemen for spending your valuable time with us and making this webinar a success. Thank you. And in the future, if we have another round of this webinar, we hope to see you again. Thank you so much.
Yeah, thank you very much, Prof. And thank you to MMU team for facilitating this, and also to the IT team for the seamless connectivity, and without which this would not happen as well. So on behalf of our NIH team as well, thank you for the kind invitation. And we look forward to a collaborative effort for many of those very exciting projects coming from your side to our side. I look forward to this cooperation. Thank you very much.
Thank you, Dr. Kalai.
Yep, thank you, Dr. Kalai.
Thank you, Dr. Prof. Faisal, and hope you guys have a wonderful day today. Thank you.
Multimedia University, because MMU is you, leading the digital future. Visit mmu.edu.my.